Okay.
Okay. Well, thank you for joining us today. This is pretty cool. We did an interview last week of a doctor here in the US, and so it'll be really nice to get perspective of a doctor in the UK. So before we start with any questions, could you just tell us a little bit about, the work you do and obviously where you're working?
Okay, so hi, thanks for having me, Novera. I'm Aliya, and I have come from Pakistan. I worked in UK in the NHS for the last 24 years, and my specialty is accident and emergency. So I trained initially as a surgeon. I did my fellowship in surgery, and then I moved to specialize in accident and emergency. And for the last 14, 15 years, I have been working in a local DGH, which is a district general hospital, as a consultant in emergency medicine.
Okay. And just for our American listeners, could you just elaborate on what the NHS is?
So NHS, as you know, is a health organization, National Health Service. I think it came into being about 70 years ago, and it is a free-for-all service. So anybody who can just walk into NHS emergency department and being seen, it's provided by the insurance or the health, by the taxpayers' money, and everybody is sort of booked into a smaller area which is within your community, which is your GP services, and the GPs can then refer patients into NHS hospitals where they can be operated for their elective work, and all the other means. However, for emergency, anybody who lives in the UK, and up until Brexit became Brexit, anybody in the whole of the European Union could just walk into any hospital and be treated.
Okay. Okay. And so right now you are working in London, and you're dealing with coronavirus patients. Can you talk a little bit about, what happens when a patient comes in until, they leave the hospital?
Mm-hmm. So because I work as a senior accident and emergency physician in my department, I've been involved from time go of how we moved from being functional without a life in COVID and into a life which is very different, and seeing COVID patients on a daily basis. So the transition had been quite challenging for us because, as you know, that it's a new virus. We didn't know about it. Nobody knew, even though there were some examples in front of us like Italy and Spain. But when it actually hits you, you realize that, yes, you're in the thick, and you start making changes. So the changes that we made were a little bit slow in the beginning, because we are now looking at end of April, and the changes that we made in our hospital started towards the end of March. So we're looking at about 20th, 23rd of March, we started making changes. And it wasn't until the 1st of April that the PHE, which is Public Health England guidelines, came, which were quite clear about the use of PPE, because that had been a very contentious thing for all the junior doctors, for the senior doctors, and for the general public, that what are we using to protect our junior doctors. So PPE, as you know, is personal protection equipment. And there was a lot of debate in the initial period of what is it that is necessary, what is that is essential that you should be using, and what was available. I'm lucky enough that I'm in a hospital which is a foundation trust, and it listens to the doctors, and it has the means to provide the PPE for the doctors. So at the moment, we have fully equipped PPE supplies. Yeah, so we do, but as we said, in the earlier part of this whole pandemic, when it started, there were these issues where the guidance was poor. WHO was saying one thing, your local authorities were saying something else. We were reading articles about what's happening in Spain and what's happening in Italy, and we were all, as doctors, making our own decisions. And some of the doctors even took it upon themselves to wear masks much earlier than the actual guidance had come that you should be wearing them.
Yeah.
So there was some confusion in the early part of this pandemic. Moving from there, as I said, we have now got a fully functional department, but we had to make a lot of changes, because whereas before anybody could just walk into the department and be seen, whether it's a little sprained ankle, or whether you're having an MI, or whether you've been hit by a road traffic accident. So anybody was coming in. Since this pandemic has become rampant in our country, people are now not coming to accident and emergencies as they were before. So whereas on a daily average, we would see 400 patients, we're now seeing close to 160, 170 patients, so far less than 50%. But the patients that we are seeing are mostly all COVID patients.
Wow.
So that's the difference that we as a specialty have seen in the last 4 weeks or so. So how do we deal with it? We have changed completely the way we work. So our whole department went through a little bit of an overhaul, which meant that the way patients could just walk in and be seen by an initial nurse and directed into different areas stopped immediately. So patients are now greeted by a specific, almost like a security guard that is standing outside the hospital, and they ask you questions, and from then part they've given a mask and they're put into different streams. So we had to do some work within our department to erect some walls, destroy some walls, make some pods, so that not only patients are safe, but also the staff that work in the department are safe from any potential patients that are coming through. So that's the one cohort that come in, which are the walking patients. So that could be anybody who's got a cough and fever, but they can present themselves.
Yeah.
Then there's a huge population, or more like about 50% of our patients that come in, that come through ambulances. So they've dialed what is an equivalent of 111-999. I don't know how it is.
Yeah,
in your
911 is the same here. Yeah.
So they would dial, they would speak to somebody, and they would have an ambulance either come through to them, or they will come through an ambulance area. And from there, they're given the mask, and they're what we call is triaged by senior nurses and seen in that area. So we had to change the way we work in our hospital, within our department, so we could have the COVID patients, which were the red respiratory patients, to be seen in one part of the department, and the other people, because they were still coming. So the chest pains, the trauma, the acute appendix, they're still coming. So they would be seen in a separate area where we are not mixing the two populations, if you know what I mean.
Yeah. Yeah.
But from the staff point of view, we just consider that all the patients who are unwell are potentially COVID, and we make sure that we are dressed, or we have enough PPE to be encountering these patients.
Yeah. And so when you do have patients who come in who are non-COVID patients, and you're saying that you're keeping them separately, is the staff mixing as well, or how is the hospital working to make sure that, let's say that there is a patient who comes in without coronavirus, and there's a COVID doctor who's seeing this patient? How are you guys managing that?
So that's, again, it was a bit of a trial and error, and we had to learn on a daily basis of how we're doing this and how we're doing that. So what we're doing now is that we do have these two different separate areas, which is divided by a door and a corridor, and the streams are both different. But the staff is expected to be in either area depending upon the need. So for example, I've got 20 doctors working in my department at any one time, and I have got this many of COVID patients, but suddenly the number could change. Yeah. So suddenly I could have a lot more of COVID patients and less of the other patients. So I would have to move my staff from one place to another. So we were having issues with the staff taking the PPE off and then putting the PPE on back again. So this was causing us wasting our PPE. So what we do is we consider that the whole area, from the doctor's point of view, is COVID. So they dress themselves appropriately. From the patient's point of view, what we do is that we then adorn extra equipment when we go and see potential COVID patients. So then on top of your own PPE, we would have another mask put on and another apron, another set of gloves when we go and see COVID patients. And they are disposed of just outside their cubicles, so that we're not potentially contaminating a COVID patient or a non-COVID to a COVID patient. So we try as best to do this kind of system, and so far it is working.
Do you think that once, inshallah, this is all over, it'll change the way that hospitals function, and this is what led up to it?
It's very difficult to say, Nawara, what's going to happen in the aftermath, because we don't know when it's going to finish. It's already our peak in UK was around the 9th and 10th. Of April, where we saw the maximum number of deaths within the hospital, and I think we reached figures something close to about 1,000. So it was just under 1,937 figure. Since then, we had a little dip. The weekend following that, we saw about 400, but then that number started rising again. So on an average, we are now seeing we're still seeing about 800 NHS deaths every day. And these are patients who are dying in the hospital. We're not considering those who are dying in sheltered accommodations and nursing homes, because there's a huge population that could potentially be dying there that the numbers are not coming up with. So for me to predict what's going to happen in my department or in the NHS, when I don't know how this virus is going to take its toll, because a lot will depend upon measures that everybody is taking right now in the country. Yeah. Because as you know, we're in a lockdown, we're doing social distances, but people are getting frustrated and they want their life to come back for all kinds of reasons, economic, social, and for us to do that as a society, that will have an impact on the deaths that we are going to see. Yeah. I mean, today there was a news by the health secretary saying that the virus maybe in summertime may go down, but until we see the figures, we can't predict what's going to happen. Yeah. So for the foreseeable future, this is how we are functioning, and it's a bit draining. It's very difficult, but that's what it is. That's what.
Right. You know. And you know, I had heard rumors about the NHS actually bringing on retired doctors to work now. Is that something that you're seeing?
So we also heard these rumors. I must say that I've not seen a single one of those doctors. And certainly not in my hospital, and you know, and thank God. I mean, for obvious reasons, they're retired. They should be enjoying their retired life. I don't think that we ever came to that situation where we really needed them, because as we started dealing with the virus, we realized that there were a lot more medical professions within the hospital that somehow became redundant. Not totally redundant, but their jobs changed. So for example, the orthopedic surgeons, the general surgeons, the cardiac surgeons, all those people who were operating before are not doing the operations because the elective lists were all cancelled. Mm-hmm. So which means that if, you know, if somebody was booked to have their knee operated, for example, they were told that they shouldn't come in because the hospital is in dire situation and it's an elective procedure. So all those kind of surgeries were held back. So the elective lists were all cancelled. So the doctors, the nurses, the medical staff who were involved in looking after that cohort of patients are now technically free. So they can come and help us. And that's how the rotas have been made, particularly with the junior doctors. They are coming and helping in COVID wards, whereas before they might be going and working in orthopedics, in geriatrics, in dermatology, psychiatry, GP, which is, you know, general public health kind of things. Yeah. So they're all coming and working within the hospital. So far we have not seen any shortage of doctors. So the retired guys are not with us.
Yeah, one of our listeners said it sounds like there's better coordination between the hospitals because of the NHS in England, which is better than what we see in the US. So do you think that that's the case, that the coordination's there because it's a government-run program? Or
yeah. I think that as I said, initially there were some frustrations because we wanted to do things like we had the ability to bring PPE on, the personal protection, but we couldn't do it because we didn't have the authority. So in some ways it tied us back because we had to listen to what Public Health England said, because we are obviously accountable as a trust, as a hospital to certain organizations, and we must do what they tell us. So in the initial part of this pandemic, there were some challenges. But once now that we're all singing from the same hymn sheet, and that's because obviously Boris Johnson, the Prime Ministers, and the other health organizations have all come together and recognized what the situation is like. So yes, I think your caller is probably right. We are pretty much working in the same sort of model in all hospitals, because my husband works in a different hospital, my daughter is in a different hospital, and occasionally we just have these chats where we share. And whereas we're not all working in exactly the same capacity, but the hospitals have all moved and they're working in the same kind of a model, so to say. So yes, there is a lot more as you can say, right, commonality. Yeah,
that makes sense. We have another question here. Did some clinicians feel like they needed extra training to treat admitted COVID patients, and was specialized training provided? So I think that goes off what you were talking about, where you had some specialty doctors whose work was redundant and they were coming to work on COVID patients. So was there any specialized training there, or just generally?
So while we will look, you know, when they have these figures that this is X number of patients we are going to see in 3 weeks' time. So because those figures we didn't see, but we had planned to to see those figures. And we had training, at least definitely in our hospital. A lot of staff were trained to deal with ventilators. So simple things to do with ventilators. Obviously, you're not going to make a medical doctor suddenly become an anesthetist, or an orthopedic doctor suddenly become an anesthetist. That wasn't going to happen. But what the trust did, and this was across all trusts in the NHS, that they had little sessions where doctors were trained on simple things like how to operate a ventilator, how to perhaps log roll a patient in ITU, where you've never done before. And this wasn't just with doctors. Other staff members were also given training to work beyond their comfort zones, so to speak.
Okay.
I am very happy to say that we didn't need all of that. That is very lucky that we didn't see that number of patients that we had originally anticipated that we were seeing. So on a daily basis, when we look at our numbers, the numbers are within manageability of what we had anticipated. And these are admitted COVID patients in the ward, on the ventilators, and in ITU. So our staffing and our doctors and staffing levels with the patient demand is, at the moment, we're managing it.
Okay, that's awesome. And then one of the questions I think is kind of geared more towards what we do. Obviously, we are a South Asian-based platform. So are there aspects of the pandemic that you see are unique to the South Asian community, especially in the UK?
So I think we have to take that apart into two questions. So one is the South Asian community that are medics, and one is a South Asian community which is Joe Blogs on the road. So if we talk about Joe Blogs on the road, the virus is attacking, hitting, and being fatal to Asians, blacks, far more than it is to the white Caucasian major population. And I think a lot of research has to be done before we can pinpoint the exact reasons why. People are talking about genetics, some factors that the Asian community and black community are more prone to diabetes, hypertension, etc. But until the research comes, I think it would be not fair for me to say what the causes are. But the facts are there. That is definitely a fact that the virus is attacking these communities far more. And we yet to come to why, whether it's just living the way they do, which is close contact with whether it's the fact that in the initial period, the recognition of the seriousness of this virus wasn't felt as much in these communities as it was perhaps felt in the Caucasian communities. So that's definitely a yes, it is. Now we come to the doctor community or the medical community. And that's something that most of the Asians are at the moment in the UK talking about it, because so far in the NHS, there have been around 120 deaths. And out of those, there's about around 20 deaths that is doctors. So that's a medical deaths. And in that, I'm almost certain they're all Asians and black population. There's not a single Caucasian in that. Now, that is a little bit alarming because the figures do not match the percentage of Asians that are present in the NHS. So at a consultant level, out of every 100, there is about 30 Asian doctors. So 55 or 57 Caucasian whites, about 30 Asians, then around next 10 or so Afro-Caribbeans, and then some Chinese and some others, etc. So the Asian population is very much overrepresented in the medical field as compared to the general population. But the way the deaths have happened so far in the medical community, again, as it's way out of proportion with the absolute numbers. And again, there's a lot of reasons why there's articles, people are talking about the same factors as in the general population. That could that be diabetes? Could it be hypertension? Could it be because of the fact that they just live more as in a close community? Or could it be the fact that in the initial period, the Asian and the African community didn't think of this as a big thing and didn't take the measures that perhaps the Caucasian community did. So these are all views that are there in articles, people are talking, but the facts are there, and a lot more research has to go in before they can come up with an absolute reason as to why that has happened.
Why it's happening. We had another question here. We've heard about healthcare workers potentially dealing with PTSD after this experience. Do you think this will be the case?
It's definitely going to be the case, because I can tell you, I consider myself as a tough cookie. But about 4 or 5 days ago, I hit a bottom low when I heard about a death of an A&E consultant who was the same age as me, and an orthopedic consultant who was the same age as my husband. And he had 4 children. So it was so surreal and so tangible that I felt, oh my God, am I going to be next? And how much protection do I need for myself to be protected? So I'm already feeling it. And I'm sure that this is going to be something that a lot of people will have to deal with once it's all over. And I think the people who are in the front line, particularly accident and emergency, ITU, they will feel it a lot more. And pathologists as well, because they're really having to deal with the mortuary side of it, which we don't even want to go there, because that is that is a very scary thing. I mean, just about 2 weeks ago, we had 2 massive containers put into our car parks just to deal with the extra space that the mortuaries couldn't cope with. And those are all realities. So these people who are dealing with, on a very daily basis, with death, which they have never done before or being trained to, they will definitely have a significant amount of PTSD after this. When the after is, we don't even know when this after is.
That's true. And have you? I mean, you had mentioned, I think, that there was someone in your, among your staff who was infected. Is that something that you guys are dealing with on the regular?
So, as I said, that when this pandemic hit us, there were so many uncertainties. I mean, there was lack of knowledge. We didn't know which way we were going. The director was coming from WHO, then PHE, Public Health England was saying something different. So there was this period of, we didn't know. Although some director was there that if you have got a fever and a cough, you must self-isolate. But people weren't really thinking of it that significantly. And I don't want to go ahead and breach confidentialities here, but I did have a colleague who had all the signs and symptoms, and he wouldn't take into self-isolation because it's not a very Asian thing to do. You know, we don't, as Asians, think that we could be unwell, or we should be, we can justify doing our job as a doctor and become unwell when all I've got is a cough and a cold and a little bit of a fever. Surely I can get on with it and I can work. So I think that element was there in a lot of areas, in a lot of specialties, perhaps medicine, perhaps everywhere, where people didn't take it as seriously. And this may well, in my opinion, be a cause of why it is so prominent in the Asian community. That's my view. I could be wrong, but yeah. I think.
No, we have grown up, that, you've got to take your job seriously, and you've got to have good work ethic, and nothing can stop you. And so I understand where they're coming from too, but, it is something that is unique to this time and that any of us have lived through. We have another question here. What is the biggest lesson we can learn from the UK's response to the crisis, and what's one thing you wish was still being done differently?
So I think the UK's response, in my opinion, even though I may have started thinking in the initial period that we weren't doing enough, I think UK's response has been very good. Yes, it took us a little bit of a time to really recognize that what's happening in Italy and Spain has hit us. But from the medical point of view, I think we're dealing with it in a fairly good manner. As I said, that at least we as the doctors, and at least me where I'm working, I have got enough PPE, we've got enough training, we've got support, we've got staff. So from my point of view, I think it is doing fine. What I would like to see happening is the measures that were so good and that have caused us not to have the 200,000 predicted deaths that people were talking about 3 weeks ago, and curtailed it to only 20 or 40,000 deaths. They're still huge numbers, don't get me wrong, they're still huge numbers, but from what the prediction was, these numbers are a lot less. So I feel that what has been done adequately, although perhaps not so timely. Maybe if it had been done a week or so earlier than when it was done, it would have been even better, like Boris Johnson sort of announced the distance measures and all those things on the 23rd of March. Perhaps that could have been a little bit earlier. But I mean, these are not easy decisions. They're never going to be easy. To do it at a government level where so much gets affected, your economy, the health, so many things are to be taken into account. So I think from what you can learn from Britain, I mean, have an NHS. That's what is one. I mean, I think people are really thanking the NHS right now. And to be fair, they should be. I think it's an amazing organization. It's there for the people, and it's a very good model for healthcare in any country. So, well, if you can trust it, it would be the best thing.
And with Ramadan now, are you fasting? How is that affecting you? It's one of those times where all systems are go, but obviously with fasting, our systems kind of slow down. How are you dealing with that?
So, yes, it's Ramadan started. Alhamdulillah, I'm fasting. It's my second day, and it is going fine. I'm going to be opening my fast in about an hour and a half, so that should be good. Yes, from a medical point of view, both my husband and I, we were a little bit skeptical with Ramadan coming because, as you know, this virus, it attacks your immunity. So if you're strong your immune system is strong and you're a healthy person, the chances are that this virus is not going to at least kill you. It might still infect you, but it won't kill you. So your immunity is very important, and I would urge to all the listeners that please make sure that your immunity is strong. And you know what the things are in immunity. You need good health. You need to stay away from stress. I don't know, that's not happening very well. But you need to be concentrating on your vitamin D levels, vitamin C levels, and eating enough proteins, etc. So with Ramadan coming, I am a bit skeptical about what if my immunity does go down. And it is likely to happen towards the end of Ramadan particularly. But then your body is amazing. It adjusts as well. So as long as you can time your fast and your sleep patterns, and you can sort of mix and match it with what you were doing, I'm lucky enough. I can do it. I can change my patterns quite easily. Some people may struggle, particularly some doctors may struggle if they're constantly going and doing early morning shifts and operating. So it is going to be a struggle, but then it's going to be a struggle like it is for every Ramadan. I don't think that this is particularly different. And I would like to add here that although a lot has changed with my work with regards to the COVID situation, the seriousness, the stress, the actual workload has actually gone down. As I said earlier, that before I was in my department, we were seeing approximately 400 patients. We're not seeing those number of patients. We're seeing a lot less. So in some ways, I'm working the same number of hours, and my stress in some ways has increased. But it has not been an exponential increase that I can absolutely not cope with it.
Yeah.
But again, that's me. That might not be the same for everybody else.
Right.
Ramadan also brings a lot of spiritual things, and it makes you deal with it, that it's all preordained. And I'm a Muslim, and as you know, that Muslims, we do believe that what's meant to be is meant to be. And it's all a will of Allah, subhanahu wa ta'ala. So with that kind of a concept and doing whatever we're doing to the best of our ability, I think we're going to be fine this Ramadan.
Yeah. No, well, thank you so much for making time for us, and we're glad that we were able to, hear some stories from across the pond, because a lot of what we hear and what we see in the media is US based, right? And so it's nice to get a different perspective from the UK. But it was great speaking to you, and hopefully we'll have you on again soon.
Thank you very much for having me.
Thank you so much. Take care. All right.